Hello, welcome to part 4 of our hypertension series. Today we'll talk about pharmacological treatment of high blood pressure in just 5 minutes. There are 4 major classes of antihypertensive medications. 1. Diuretics, 2. Calcium channel blockers, 3. ACE inhibitors and angiotensin receptor blockers, and 4. beta blockers. Diuretics, also called water pills, are usually thiazide diuretics like hydrochlorothiazide and chlorthalidone. If the patient is already taking 2 blood pressure medications, the third one should be a diuretic, otherwise blood pressure will not come down. Diuretics are cheap, effective, and useful in patients with edema and heart failure. The disadvantages are electrolyte problems, especially low sodium, low potassium, low magnesium. They also can raise blood sugar and cholesterol, and you have to monitor blood tests. Now, loop diuretics like furosemide, bumetanide, and torsemide are used in patients with advanced chronic kidney disease and in heart failure. Second class is calcium channel blockers, usually dihydropyridine, such as amlodipine, nifedipine, and nicardipine. The non-dihydropyridine type, like diltiazem and verapamil, are used less often. They're not very effective. They're used by cardiology to lower heart rate. Advantages: they're cheap, very effective. They work very well with ACE inhibitors and angiotensin receptor blockers, and you don't have to monitor any labs. The disadvantages: they can cause leg edema, they can cause headaches, and in case of non-dihydropyridine calcium channel blockers, you can have bradycardia. The third class is the renin-angiotensin-aldosterone inhibitors. Here we have the angiotensin converting enzyme inhibitors like captopril, enalapril, lisinopril, anything that ends with pril. You have your angiotensin 2 receptor blockers like losartan, valsartan, irbesartan, anything that ends with sartan. And lastly, you have the aldosterone inhibitors like spironolactone and eplerenone. So 3 classes under this number 3. Advantages: they decrease morbidity and mortality in many conditions like heart failure with low ejection fraction, like patients with chronic kidney disease in case of proteinuria, and in diabetic kidney disease. Disadvantages: here you have to really monitor labs. You can get high potassium, you can get elevation in creatinine. In case of ACE inhibitors, cough is seen in up to 15% of patients. You can have worsening kidney function in case of, say, renal artery stenosis, dehydration, or low blood pressure. Last major class is beta blockers. They can be selective like metoprolol and atenolol, or non-selective like carvedilol, labetalol, and propranolol. Now, selectivity relates to whether they work only on the heart or whether they can affect the lung. If they are non-selective, you have to be very careful in patients with asthma. They should not be your first go-to medication. So they're not first line unless there is a reason. What is that reason? Heart failure with low ejection fraction, post-myocardial infarction, cardiac arrhythmias, and in many cases, migraine headaches. The disadvantages: obviously, they cause bradycardia. This is how they work, and they can cause fatigue. They're not the best medications in a patient who is young and active. But if you've already used a diuretic, a calcium channel blocker, and an ACE inhibitor, for example, then number 4 is going to be a beta blocker. Then you have your add-on antihypertensive medications. If the blood pressure is still not controlled and you cannot find any reason, in that case, actually, you have to make sure that the patient is following a low-salt diet, that they're not using any drugs like cocaine, that they're not drinking alcohol, etc. So here you have your direct vasodilators like hydralazine and minoxidil. Here you have a lot of side effects. Edema, you can have increase in heart rate. You have your alpha blockers like doxazosin and terazosin. Those are helpful if you have also an enlarged prostate. You have your alpha-2 agonists like clonidine. This medicine can cause sleepiness, can cause bradycardia. If you stop it immediately, you can have real rebound in blood pressure. Finally, you have your aldosterone antagonists like spironolactone. We mentioned that when we talked about class 3. These medications are helpful if you have someone with heart failure and low ejection fraction, and if you have resistant hypertension.